All right. Hello, everyone. Welcome to the first Washington Healthcare Facilities Community of Practice webinar of 2026. We're really excited to see everyone again and get started with another exciting presentation. Liam, if you can go to the next slide. So my name is Ryan Kronk. I'm with the Water Institute, and we are the Secretariat for the WASH and Healthcare Facilities Community of Practice. We're excited to see lots of new faces this month. And so we'll kind of give a few announcements and reminders before we get started. Um, and then we'll have our presentation by PATH and the Ghana Health Service. And this is some really exciting new work, and we're really excited to hear from it. And just to let everyone know some housekeeping rules, we will have a Q&A at the end. Please, throughout the presentation, drop your questions in the chat, and we will triage those to ask our speakers at the end. And if you're feeling bold at the end, you're welcome to also unmute and ask your questions directly. We'll have time for that at the end. Next slide, please. So I want to go ahead and advertise. We've already got our next webinar set up with Uptime Global on securing public commitment for results-based funding of drinking water services in rural healthcare facilities. So we're really excited about that. Nikki's going to drop the link to register for that in the chat if you'd like to go ahead and sign up for that. Next slide, please. Many of you are also new or may have just registered for our last webinar. We'd like to remind you that we do have a mailing list that you're welcome to join. We don't spam you too much, just maybe once or twice a month with some announcements about upcoming webinars, resources, etc. This is a way to stay abreast of our upcoming schedule. We are trying to get plan out several months in advance so you can plan and have those on your calendar. So please feel free to sign up on our MailChimp list. Nikki's also dropped that in the chat as well. If you're not on that already. Next slide, please. And as always, we want to hear from you. In this newsletter, we love to share stories and project successes. So if you have ideas for, say, a future webinar or a project that you'd like to share, please send that to us to our email, washingtonhcfcop@sph.unc.edu. Nikki will drop that link in the chat because I know you can't click on it. We'd love to hear from you if you have ideas for webinars or project success stories. Next slide, please. So with that, I'm going to turn it over to our colleagues from PATH and Ghana Health Services. We have from PATH, Adam Drolet and Kofi Aburam. And then also from Ghana Health Services, we're delighted to have joining us Gloria Ntaukumi and Dr. Lawrence Ofori Bodo who's the Director of Institutional Care Division at the Ghana Health Services. So with that, I'll turn it over to Adam. One last thing I will say, and we will share this. This work has a publication that's coming out, and unfortunately it's not out today, but it will be out tomorrow. So we will, when we share the recording of this webinar, we will also share the link to that work so you can read about it in more detail. So with that, I'll turn it over to Adam and Kofi. Thank you for joining us today.
Thanks, Ryan. It's a delight to be here. Good morning, good afternoon, good evening, everyone. I'm Adam Drolet, and I'm here joined with my colleagues from PATH, Kofi Aburam, and our colleagues, close partnership with the Ghana Health Service, who come in and speak later. Today, we'll be presenting on our work that spans several years on onsite chlorine generation in Ghana. And next slide, please. So this work really it demonstrates the potential of a powership, or the partnership between PATH and an organization and a government entity. And where this work stemmed from is around improving patient environments and hygiene within health facilities. So we know that healthcare-acquired infections are a scourge of health systems globally. They affect hundreds of millions of patients, require a significant financial burden for patients and health systems alike. In Ghana, data shows anywhere from 8 to 12% of patients will acquire an HAI during their stay. And the the potential and the risk for patients within health facilities is not just from HAIs and surface vectors, but also from contaminated drinking water. There's evidence that shows that facilities have anywhere from 36% of samples had E. coli present and 79% had no chlorine residual in a 2022 study across 20 health facilities. And so there's again multiple risks that are happening here. On the flip side, we know that improved wash and IPC services have a significant potential to reduce HAIs and infections within patients anywhere from 10 to 70%. So a large range, but a significant potential. Next slide, please. So with the Ghana Health Service, we began focusing on what are ways to address these challenges. And we focused on the availability and supply and quality of chlorine. We know that chlorine is widely available, yet its availability within health facilities was a noted challenge. In 2019 landscape as a survey that we did across 10 facilities, and these are district hospitals, we found that there's an average of 28 days per month that facilities face without any chlorine. So that period, almost a month of stock out per year with no chlorine. The reasons for this and root causes were mostly supply chain issues with transportation, with financing and costs. And beyond that, we heard several indications that there may be challenges with chlorine quality. There were significant challenges with dilution, as chlorine can come in several different forms, whether it's granules, liquid, or powder, and different concentrations, anywhere from 3 to 70%. Getting to that 0.5% for surface and equipment disinfection was a challenge that we consistently heard. Next slide, please. So this set up the kind of the basis for, again, a partnership and a project that started in 2018. PATH and the Ghana Health Service aim to improve infection prevention control practices within health facilities by working with our partners at Aqua Research and introducing and scaling up the Aqua Research Stream Disinfectant Generator in the Ghana Health System. We had three main objectives. One was to again, with the Ghana Health Service, develop evidence to show around reliability, performance of the device, acceptability by health staff, issues on cost, and the effect on health systems. Does it really improve those challenges and barriers that were presented earlier? If so, then begin going through the regulatory and policy approval process to introduce that device within the Ghana Health Service. And then the second objective was around developing national scale-up strategies and district-level implementation plans. So we didn't want to stop with, there's the evidence, here are the policy approvals, but how does it get integrated within the health system? And finally, explore different use cases for the stream. That chlorine can be used if it's produced on site for both disinfection and water treatment, as was shown in the challenges above. So again, this is a long-standing partnership from 2018 to present. And next slide, please. I'm excited that Kofi will talk about the results. Just quickly, this is the Aqua Research Stream Disinfectant Generator. I see some of our colleagues from Aqua Research are on the call. If there are questions about the device, please reach out to them. Broadly speaking, it's an on-site chlorine generator. It is a pass-through device, so it addresses some of the issues around the product category with batch-based chlorine generators. If that doesn't quite make sense, ask them. They'll give you a good response of why that's important. It produces a consistent 0.5%. So it addresses that dilution issue, which is a huge headache, again, for health staff. Produces about 5 liters per hour. And again, as a reflection over the years of this work, Aqua Research has been a fantastic partner, has taken on costs to redesign some of the components themselves based on the evaluation and the user feedback that we've had. I can't speak enough highly of them. Next slide, please. One of the interesting components and aspects of the device that I want to highlight too is the device is able to relay telemetry data, so performance data to a cloud. And we were able to use this data to validate performance and reliability and really build some of that confidence within Ghana Health staff, but also use it as a mechanism to train biomedical engineers for maintenance repair services uh, across different regions in Ghana. So really interesting kind of visualizations that we're able to pull from this device, uh, monitor via cloud and that kind of asset management using Internet of Things capabilities. Next slide, please. So uh, that's the setup. And now I'll pass it over to my colleague Kofi. He'll talk about 3 rounds of evaluation, highlight some of the results that were achieved during those evaluations, and really the resulting milestones and decisions that were taken. Kofi, over to you.
Thanks, Adam, and good day, everyone. So taking off from where Adam just stopped, this project has gone through a number of phases, and as Adam mentioned, we've done 3 phases of pilot introduction and evaluations. And the first really was, very opportune or happened in a very opportune period in 2020, during the height of the COVID-19 pandemic, where infection prevention and control and basically resources for IPC became a big topic and a big issue. And chlorine was one of the things that was identified as something that need to be augmented in trying to deal with the IPC issues around COVID-19. So we're very fortunate that just around the same time, the first batch of devices for our project had arrived. And so we piloted them in the eastern region. We introduced 8 devices in the region, and our main focus of doing this was to understand how the devices placed in 8 different healthcare facilities would improve the availability of chlorine and reduce or eliminate stockouts. If it would reduce the cost of chlorine supply, and then also if the device would be accepted by users based on its performance, its user friendliness, etc. So we did this over roughly 2 years, where we evaluated the device based on its performance, and then also looked at these other metrics that I talked about. Some of the key results, and you see on the slide, we've listed the healthcare facilities that we piloted the device in. And some of the key results that we saw over this period was the fact that prior to the introduction, facilities were facing an average of about 45 days where they had no chlorine. And you can imagine during this period when we're managing COVID, it was going to be a disaster. But the introduction of the device really brought this new phase, or opened up a new chapter, where none of the facilities where the device was introduced ever faced a stockout during the period. In terms of cost, we collected data on how much facilities were spending on chlorine prior to the pilot introductions, and we found averagely about 33% savings were being made if you compare the cost of chlorine that was being procured prior to the introduction to the cost of the chlorine that was produced using the device over the period. Now, in terms of acceptability, we interviewed users in the healthcare facility, from management all the way down to the device operators or users, and all of them agreed to the fact that this device was acceptable. They accepted the use of the device. They acknowledged that the introduction of the device had improved IPC practices by increasing the availability of chlorine. There was also cost savings that they could see clearly from the data in terms of what was being purchased and what was the cost of producing with the device. They also perceived safer environments, because as long as there was enough chlorine to use within the facility, they were sure that IPC practices were being carried out correctly, or to a large extent, chlorine was available for use across board. There was a strong buy-in because right from the beginning we involved um, the different technical people within the regions. We specifically, because this was a device, we brought on board the biomedical engineers because you wanted to make sure that the performance of the device was always assured or guaranteed, and they supported greatly in making sure that the devices were being maintained, and also when there was a need for repairs, they were there to provide that support. So that created a lot of goodwill in terms of buying when it comes to the use of the device, because that support was always available. Next slide. So some of the key milestones or what we achieved within this first phase, the stream was validated basically based on its performance. It was agreed that this was a device that was fit for the purpose for which we introduced it. It notably addressed key health system and operational and supply chain needs during the pandemic. We didn't have to worry about transportation of chlorine from a supplier or manufacturer to a healthcare facility. We didn't have to worry about the quality of the chlorine because the production was being done locally in the facility. We didn't have to worry about shortages because the inputs required for the production were readily available for the facilities to do their production. So these observations led to, strong backing or strong support from the Ghana Health Service. We're all trying this out to see how this was going to go. And the then director of the institutional care division, who was, deeply involved in all of this, made a call that this was something that needed to be expanded to other regions. And before we did this, the observations we had made about the performance of the device, we had shared with the manufacturers, Aqua Research, and they did major redesigning of some components. If we were going to expand this, we needed to make improvements to the device to make sure that its performance was reliable, and the device was much more robust than the original or the first version that we had used for this pilot introduction. So the manufacturer also made quite a bit of investment into improving the robustness of the device. Next slide, please. Now to the next phase, beyond this observational monitoring that we did of the devices in the Eastern region, we decided to look at other parts of the country, other geographical locations, first of all, to understand what the specific context related issues will be in terms of, introducing such a device into those areas. So we introduced 18 more of the redesigned or the tuned up devices into 12 healthcare facilities in 3 different regions, in 3 different, would I say, geographical locations in Ghana: the Central, Ahafo, and the Volta regions. Those who have worked in Ghana before might be a bit familiar with these regions, but these are regions with distinct characteristics. So we wanted to understand how the device would work there. Our objectives, of course, were still to assess the reliability of the device. We wanted to see how chlorine availability can be improved. And this time we added an additional layer of computing the total cost of ownership of the device, as well as the cost effectiveness. So between June and December 2023, we introduced the devices across these facilities. We had a combination, you can see the list of facilities that we had, a combination of hospitals and health centers, because we also wanted to understand which of the use cases was going to be most appropriate, and what will be the contextual issues that we'll need to consider for scaling up if we got to that point. So some of the key results that we observed here. During the study period, the devices across all the facilities maintained a 95% functionality rate. So for 95% of the period, the devices were functional. We had a few challenges here and there, the 5% of the time. Some were contextual, which were user-related issues that led to a break in production. Some also were device-related issues, but all in all, they were resolved very quickly. I would say in less than 30 days, all these issues were resolved once they were reported. We did these, both between the biomedical engineers at the regional level with support from Aqua Research and also the team from Path. So the response time was very quick for all the devices that had any form of issues. Now, prior to the evaluation of the introduction to these facilities, they were seeing roughly 37 days on an average of stockouts where there was no chlorine available in the facilities. However, with the introduction of the device, once again, in this case, none of the facilities where the device was introduced faced or experienced a stockout within the period when we carried out the evaluation. And of course, beyond the evaluation, we've continued to follow up with these facilities, and stockouts have become a thing of the past, largely mitigated or largely reduced or non-existent at all in some cases. Prior to the evaluation as well, we sampled chlorine samples in the 12 healthcare facilities, and 10 out of the 12 had degraded chlorine. So most of the chlorine that was being purchased from the open market was degraded, and this can be attributed to so many different factors. You can't tell at what point the degradation starts and at what point the degradation ends. But the point to be made here is having the device available within the facility to do the production guarantees higher quality or the right quality of chlorine for use within the facilities. Now, we saw that facilities on an average increase their chlorine use by about 50%. So this also goes to point to the fact that in periods before the evaluation or the introduction, facilities may have been economizing or they may have been using less volumes of chlorine because of the issues we've talked about, the non-availability, the high costs, and so on and so forth. So the introduction of the device saw facilities feeling more comfortable using as much chlorine as they required for their needs. And so we saw on an average an increase of about 50% more in terms of volumes of chlorine that they were using within the facility. Now, 42% of the facilities reported lower chlorine cost per liter. And so across board, what we saw also was cost savings ranging from about 64 to 83%. And that's a huge cost saving margin, no matter how you look at it. 64 to 83%, depending on the level of facility, was very huge cost savings as compared to the amounts that the facilities were spending on purchasing commercial chlorine. We also carried out a study to understand the DALIs and the SSI averted due to the increased chlorine availability and then the increased IPC practices. And we saw savings being made on the DALIs and then the healthcare acquired infections. In this case, we're measuring them by surgical sites infections, and significant costs were being saved by patients and also by the facility by avoiding these due to the availability of chlorine and increase in IPC practices. Now, we also, through this evaluation, established strong capacity, or we developed strong capacity for the regional biomedical engineers, where they have continued to take care of the PPMs, and also support the facilities with any sort of repairs that they need to do on the device whenever there are functionality issues. And this capacity has continued to grow, and the experience has been passed on from one biomedical engineer to another. Some have moved all the way to even train local personnel within healthcare facilities to provide some of these support services for the device. Next slide, please. So some of the key outcomes or the key milestones that we have scaled in this phase or in that second phase was that based on the evidence that we had gathered from 2020, the buzz around the device started, going higher and higher. We kept hearing very good stories. The evidence was presented at different forums. And basically, the call came from the ground. It came from healthcare facilities that had visited some of the pilot sites and seen the device and how it was improving the IPC status of those facilities. And the calls just started coming from the ground up to see a greater scale up of the device. And this call led to the Ghana Health Service allocating some funds for the improvement of the network of practice program, to procuring some of these devices to be distributed across a wider segment of the healthcare system. At the same time, when we carried out this phase of the project, we tried to look at how we can align the stream introductions to IPC capacity building within healthcare facilities. So while you're introducing the device, you also have to look at ways of improving the in-service capacity of staff, so that the use of the chlorine actually benefits the facility, or the availability of the chlorine actually benefits the facility through quality or improved IPC knowledge and skills. Now, we also worked with the in-country distributor of the Aqua Research Stream device and created a network between the distributor, the healthcare facility management, the regional biomedical engineers, so that there will be an established platform to provide support. And through this platform, facilities are also able to, access parts for repairs and maintenance of their devices. And this has proven to be very useful, as we have taken a step back as Path, and this platform has basically created the situation where there's an ecosystem for the long-term sustainability of the use of the device. Then, in terms of financial analysis that we generated through this study, together with the Ghana Health Service, we came up with the total cost of ownership of the stream. This total cost of ownership modeling that we did was looking at the financial requirements that were needed for capital expenditure, operational costs or operational expenses, to address the requirements of chlorine at different levels, the district hospital, the health centers. And one thing that I didn't mention before is one of the things that we learned along the line was, for instance, if you were introducing this in a district hospital where they had greater demand, the dynamics were different. You would require more devices because of the higher demand of chlorine. And so the capex and opex, when it comes to that level, and when it comes to the level of a health center, are different. So all these analyses were done through the evaluations that we carried out. Next slide, please. So the third phase of what we did as part of this project was to now understand how the device can be introduced into the network of practice, which is something that the Ghana Health Service had already started rolling out in across the country. So the network of practice is basically the system where facilities are grouped in networks where they share resources and services just to maximize or optimize resources across, specific catchment areas. So we decided to go into one of the regions, the Volta region, which had a well-established network of practice. And the background to this was the fact that based on the financial analysis we did throughout the evaluation, we realized that at facilities like health centers, they were yet to optimize the use of the device. So we're not seeing the break even. The break even analysis showed that it was going to take much longer for them to reap any financial benefits or proper cost savings from using the device, except if we put them into a network to optimize the use of the device and therefore bring the break-even period much closer than farther away. So 28 healthcare facilities across 6 networks of practice were selected for this evaluation. And in this system, the hub in each network was going to be the production site, and they would produce to support the spokes within the network. And so you have the list of the hubs there, and then the spokes that feed into those hubs are also listed on the side. We saw hubs that had up to 6 facilities that they were supporting within their networks. And the objectives really were to look at what the chlorine supply cost will look like within a network of practice, what will be the total cost of ownership across a network, what will be the improvement in availability of chlorine, the quality of chlorine, and the reliability of the device in general. So we carried this out we had our ethics approval from March, carried the evaluation out from May all the way through to November. We're still analyzing our results, but preliminarily, some of the results that we've seen are that the stream addresses chlorine demand for networks of practice. So in the network of practice, we saw that in totality, there was an increase in chlorine stock within each network. And when we look at the estimation over a year, we are looking at an increase of around 952%. And we are seeing this based on the comparison we made with the chlorine stock availability that existed before the introduction of the device. So 952% increase in chlorine availability is really significant. And you can also attribute this to the fact that the lower you go in the health service delivery chain, the more difficult it is for resources and supplies to reach some of these facilities. So they barely had chlorine for their IPC, and where they had it was so insufficient. So with the introduction of the device, we saw a massive uptake and a huge increase in the volumes that could now reach those levels of service provision. So that already gives credence to the idea of introducing the stream in this model or in this system. We also saw in our analysis the costs that was being incurred for the procurement of chlorine prior to the introduction, even though this chlorine was not adequate for their use, we're still seeing 60% average annual cost reduction in chlorine supply costs. Also, we saw the huge compromise in the quality of commercial chlorine that was available at the time we started the introduction at this level. And this was not a surprise to us because we've seen this run through the different phases, and at every point we've seen that the quality of commercial chlorine is always somehow compromised. And this is something that needed to be addressed. And at each phase where we've introduced the device, this is one of the key things that has been sufficiently addressed. So even though it was not a surprise, we're happy that this was coming down to this level and was going to address this issue. Next slide, please. So here you can see the comparison between the chlorine volumes that were being used by the facility. The lighter red color is the volumes that were being used by the facilities, and this is over an annual period. So in each of these networks of practice, you can see the huge jump in the chlorine availability, for an annual extrapolation. So this is what the difference looks like. The 958% increase in volumes available in every network. Next slide, please. So this next slide looks at the cost. And once again, the lighter red shade looks at the cost that existed before the introduction of the device. And the darker red shade looks at the cost of the chlorine that is being produced with the stream. And we can see the obvious difference or the obvious reduction in cost by just using the stream as the alternative for chlorine supply within these networks. So it goes without telling the solution that the stream brings. Next slide. So here also we're looking at the quality of chlorine. So over the period, we're testing the chlorine samples that was being distributed within each network that was from the stream. And we found consistently that the quality of the chlorine that was from the stream met the 5,000 ppm standard all of the time. There were a few periods when we found chlorine samples from the stream that didn't meet the standard, but this was because the chlorine had been stored for a significant amount of time. Conversely, or interestingly, but not surprisingly, commercial chlorine that we tested over the period were all below the standard. And this is something that wasn't a surprise because we've seen it over all the phases of the project, and it was a key issue that we're hoping to address with this project. So, like I mentioned, of the 51 stream samples that we collected over the period, only 9 samples fell outside the 5,000 ppm range, and these are samples that were being tested after 10 days of having the chlorine sitting down. And for most facilities, the chlorine that they were collecting was being used in 2 days or 3 days. So the 10-day sample were outliers where the chlorine had sat for that long, because we also tried to test some of these samples to understand how long the chlorine could sit before degradation would set in. So we can see from the graph or the box plot the consistency that we saw with the stream chlorine concentration and what we saw with the commercial chlorine samples. Next slide. So some of the key milestones or the key fallouts from this phase of the project, we always target to have or we always target to have sustainability built into each phase of this project. And this particular phase, the sustainability issues were around the acceptance of the device. So the districts who are the closest management or who are the closest in terms of management of the networks of practice took took up the responsibility of ensuring the continued use of the stream beyond the evaluation period. They started this by making sure that they had budgeted for the procurement of supplies for the hub facilities to do the production. They also started providing transportation support because the hubs have to move, the spokes have to move to the hubs to collect their chlorine as well. And so they started providing transportation support for them. The equipment managers were deeply involved in all of this to ensure that they were providing the support required to ensure that the device was properly maintained and that all repair services were provided promptly. Also, the results that we've seen so far from the hub and spoke evaluation, we think will be a good basis to inform the distribution of the additional units that the Ghana Health Service is procuring for the scale up of this innovation to other parts of the country. Next slide, please. So as Adam mentioned earlier, and I think Ryan also mentioned, we have a publication coming out on this study tomorrow. And so will be shared as part of the follow-up email from this. But we've had a number of other resources that we've put together based on this project. We have some learning briefs. We have some articles on our website. So we'll make sure we make these resources available for further information. Next slide. So at this point, I'll hand over to our key partners and collaborators, the Ghana Health Service, represented on the call by Gloria Intokumi, who's one of the deputy directors at the Ghana Health Service, and also Dr. Frebuedu, I see him on the list of participants, who's the director for the institutional care division of the Ghana Health Service, for them to talk a bit about the scale up and moving forward from where we've come from in terms of this study. So I'll pause here and hand over to Gloria and Dr. Frebuedu. And you can move to the next slide, please.
Okay. Thank you very much, Kofi. And good afternoon, good morning to you all, ladies and gentlemen. I'm Gloria Ntokumi. Let me open my video. All right. So I must say we were very grateful to have this device to help our facilities. So just as has been said, since 2020, the COVID time till now, when we were exposed to the facility, in fact, the initial enthusiasm and excitement that came with it was very massive. And for using the device, we have all seen the benefits of having the device around to be able to get particularly not only the chlorine, but the right concentration that is needed to minimize and prevent infections. And so because of that, facilities demanded for the device. And so the service as it stands on its own went ahead to do some procurement, particularly for the networks of practice, so that the lower level facilities will be able to have access to chlorine to be able to use it efficiently to minimize infections. And so the service has made some procurement of about 200 devices and then have sent them to the regions. We have various levels. So we have our regional, we have a district level, and then we have the facility level. And so from the national level, currently 200 of the device were procured and sent to the regions. And so facilities will have to be trained on the use of the device before they can start. So at the moment, it has been sent to the regional levels. And as has also been said already, for the maintenance of the devices, most of the regions have the equipment officers who were earlier on have been introduced to the device, the use of the device. And so they will support with the training and the maintenance of the device as it goes on. And as a service, we will go on to be able to monitor the practices to see how well the devices are being used to prevent and minimize infections. And so as it stands now, Ghana Health Service have endorsed the use of the device and have procured. I believe that it will be a gradual process. We will use this initial 200 devices, and then as and when the demand comes and we are able to procure more, we'll move on and see how it goes. So in a nutshell, I think that is what I have to add on to the presentation. Thank you, and over.
Thank you very much, Claire. So I saw Dr. Feribuedu on the call as well. I don't know if you have anything to add to it,
Yeah, I
Director.
think he's here. Yeah, Director.
All right. Thank you very much. I think all is said. A lot of effort have been put into make sure that especially the lower facilities that cannot that cannot purchase this high bulk of chlorine have these devices. So as Rogoria has rightly said, effort has been made to facilitate implementation of these devices that have been procured into functioning at the lower facilities where we have a high turnover of the use of chlorine for disinfection and cleaning of very critical items. So I think that is what I want to say for now. Thank you very much.
Great. Well, thank you to our colleagues from the Ghana Health Service. Thank you to my colleague Kofi. I do want to highlight one thing that it was on the basis of the partnership starting in 2019 and that trust that was developed, building and investing in that relationship, that everything else kind of flowed from that. The ability to tackle challenges together, to generate the evaluations and evidence together, to address those regulatory approval requirements together, walking kind of hand in hand throughout this process is what allowed us to kind of achieve these results, and ultimately that ownership by the Ghana Health Service is what we're most proud of and excited and here to continue to help. So with that, I think this is the last slide. You have any other questions? I've been trying to address them in the chat, but if there are other questions, please let us know.
Yeah, Adam, thanks for addressing all the questions in the chat, and thanks to all the presenters for a really great and insightful presentation. Is there anything in particular you might want to just elaborate on a bit further for the anyone who might not have been looking at the responses in the chat? Or if any of the other presenters want to comment on the questions that have been asked. Ralph, if you... Ralph, maybe you go first, and then Rodney, if you'd like to jump in with a question.
Yeah, I would just like to compliment you on this program, and that this is the kind of infrastructure and metrics and data and networking that Rotary loves for their global grant projects. And I just wondered how many global grant projects you all have done, if any, or how you might reach out to do more.
Yeah, thanks, Ralph. From the path side, we have not implemented any of the Rotary Global grants, but obviously would be keen to do so. This funding was made possible by several continuous and generous grants from the Hilton Foundation. And this work officially ended in November and December of this past year. And so it's now being led by the Ghana Health Service in Ghana, by the Ministry of Health in Uganda, and there's some work up in the Amhara region of Ethiopia as well. But happy to discuss more if you're interested.
Great. I mean, Rotary is looking for, let's say, local to local partnerships, not big corporations or companies. And I think you all are well positioned to take that on.
So we attended Rotary International in Singapore a couple of years ago. We did not attend last year in Calgary. And Ron Denham is the guy that we have been talking to high level at Rotary. And so we're very interested in working with Rotary. We haven't done any projects, interestingly, with Rotary. We'd love to. But we're anxious to talk to you more about it.
Yeah, you guys are filtering down now. I'm at the ambassador level. So I advise districts across the US and world about, different types of WASH projects and technology. So, your message is getting out. So, keep it up.
Thank you, Ralph. We'll keep working on it.
Thanks, Ralph and Rodney. Any other questions for our presenters? Or anyone from the chat? Give me another second. Ralph, is that another question?
Yeah, I wondered, what countries are you working in besides Ghana right now?
Yeah. So this project work was done in Ghana, Uganda, and Ethiopia. We've helped advise partners to launch and implement these devices in Kenya as well, in Mozambique. I think Rodney can probably speak to other countries in which the devices are currently located.
Yeah,
Thank you.
there have been a number of countries in Africa with various NGOs from Catholic Relief Services, World Vision, and others. And we're operating, we work with, Japan and Korea and India and other places like that. So we're operating and selling these systems worldwide, and we have a full range. This is the smallest, what I call commercial scale generator. But we have even individual handheld devices all the way up to full scale production. And it's not just in healthcare. We're in, drinking water systems and cooling towers and aquatics and lots of other, places.
Yes.
So we can, if you're looking for chlorine, we can produce it. So.
Great, I'll give another second for questions while we wait. I just want to remind everyone, Nikki posted in the chat, we do have our next webinar on February 18th at 9 a.m. Eastern. You can go ahead and preemptively register in the link. It's with Uptime Global. They've got some really exciting work on results-based financing. And if you're not on our newsletter, please go ahead and sign up. You'll get the recording to this session and also the publication from Adam and the Path team. And so with that, I think if there's no other questions, we'll cut you all loose a few minutes early. Thanks for joining this month. We look forward to seeing you next month. And please don't hesitate to reach out if you have any questions or other ideas for webinars. Talk to you all soon.
Thank
you.
Thank you very much.
Thank you.